Hello and welcome. Today's presentation is in fulfillment of my capstone project for the Certified Sex Therapist program at the Sexual Health Alliance. My name is Stephen Stewart, and I'm a licensed professional counselor practicing in St. Louis, Missouri, where I have a private psychotherapy practice focused on serving individuals living with HIV, as well as their loved ones. I'm also an HIV educator, an advocate, a researcher dedicated to advancing clinical practice and compassionate care for people who are impacted by HIV and AIDS. Over the course of my advocacy work, for nearly 40 years now, I've supported individuals, couples, families, each navigating diagnosis, treatment, and the emotional fallout of living with HIV. And I've also helped to train clinicians to provide evidence-based, stigma-free care for people living with HIV too. Today, I want to center our discussion on what I believe is perhaps a simple but powerful idea, and that is promoting HIV-informed psychotherapy. It's not just an add-on to our understanding about sexual health. It is essential to effective sexual education and ethical care that promotes health and wellness for our clients and the people that they love. It's really important, I think, for us to understand what HIV is and what it is not, know some of the science of transmission and prevention, and then integrating that knowledge into compassionate and effective therapeutic work. How do we do that? Whether you're a counselor, a therapist, a coach, an educator, we each have a part to play in that work. My goal in today's presentation is to give you some practical frameworks and language that you can use to support clients. And together we'll examine common myths and harmful beliefs that undermine care, as well as clinical strategies for addressing fear, internalized stigma, and of course, shame. So today's talk is about more than just facts. It's about changing how we show up as professionals so that our clients, that they can feel seen, they can feel valued, and most especially, they can feel empowered to make good healthcare decisions as well. Sometimes people will ask me, well, what does HIV, a medical diagnosis, have to do with someone's mental health? And it turns out actually quite a lot. And that's what I'm going to try to present to you today, information about how HIV can show up in the therapeutic setting, and how can we implement some tools and strategies to really address it forthrightly in a way that supports clients most. Let me share my screen and we'll get going. So today's discussion is on HIV-informed psychotherapy treatment and how do we approach that work. So let me just share a bit about my professional background. First of all, I am not a medical provider. I am a clinical counselor, and I have not been to medical school. So please do not take anything that is stated in today's presentation as medical advice. Always consult your doctor when making healthcare decisions that are right for you. But as far as my background goes, I had a career in government services. For a number of years, ultimately left government service, and then found myself working in pastoral care. After about 6 years of pastoral care, where I got introduced to the idea of counseling, I went back to school, did a program in clinical psychology, and then completed another program in clinical mental health counseling. So for the last 15 years or so, I've been really devoting myself to social services. I've been a victim advocate and crisis responder for those impacted by violent or sexual crime. Often HIV was a topic that we had to have a discussion about. I've worked in outreach and education centers in AIDS service organizations, reaching out to the community and then helping to provide education, information, testing, and support around HIV and STI diagnoses. I've also worked in medical social work settings and clinical infectious disease practices. And I've also served as the Ryan White case manager. I'll speak for just a bit about what the Ryan White program is today, because it's really important for us to know that. And I've also been involved in research projects. Most recently, I was involved with a project called 2IS. This was a project that HRSA, the Health Resource and Services Administration, designated as a special project of national significance. And I was one of the researchers in the St. Louis site where that was taking place. That data has not been published yet, so I'm not going to talk so much about the 2IS project today, but maybe sometime I'll get the chance to come back and give a more thorough discussion about what that program is and why that was so impactful as well. So I looked at the issue of HIV and AIDS from a lot of different lenses: psychologically, medically, socially, academically, and even legislatively. I have I have no financial disclosures to report in providing this talk today. My personal background related to this topic, so I'm going to wait until the very end, and I'm going to come back and just kind of share with you just a few thoughts about how I got involved in this work and why it's so meaningful to me today. When I came to Shaw, I didn't know anything about the principles of sexual health. But having since learned about this, I've really tried to implement this not only into my own life, but in the way that I work with clients too. Today, we're going to focus on two out of the six. First of all, safety. How do we minimize the risk of STIs and pregnancies through protection and open communication? And then also, how do we have an open and honest dialogue about desires, boundaries, consent, and especially sexual health? This is critically important information that we need to help clients understand, as well as understand for ourselves and apply it to our own lives as clinicians. Going back to when my time in government service, I was 20 years old working in the House of Representatives for the majority leader. That was Dick Gephardt, who was also from St. Louis. During my time in the leader's office, a big part of my work was to follow certain pieces of legislation through the legislative process and report on problems or issues that might be arising as it moved through Congress. A large part of my work was focused on what was then known as the HIV/AIDS Care Act of 1990. This later became known as the Ryan White Care Act. Ryan White was an 18-year-old teen who had hemophilia. He contracted HIV through a blood transfusion, and he spent the last number of years of his life fighting against the stigma of HIV and AIDS. And unfortunately, he died due to his complications of his diagnosis after the blood transfusion. The Ryan White program, the Ryan White funded services, this is the largest federal program for helping people with the HIV and AIDS in the United States, literally responsible for saving millions of American lives. And the Ryan White Care Act, it passed by Congress in 1990 with broad bipartisan support. However, I will tell you, and this is a talk for another time, there was a time when it did not look like it was going to make it through Congress. And it really is a remarkable story how we now have this program, which is so critically important in the treatment and support of those living with HIV and AIDS today. So the Ryan White system, and in order to qualify for what's called Ryan White funded services, there's a number of things that you have to, a number of criteria that you have to meet. First of all, you have to have HIV. And when somebody is diagnosed with HIV, oftentimes that's first done with a rapid test. Maybe it's a finger stick, a blood test, or a quick oral swab. Uh, Once you're diagnosed with HIV through a rapid test, then a physician will order a more specific test to run a confirmatory test to make sure, in fact, that you do have HIV. So you've got to have HIV to qualify for these services. You must make less than 300% of the federal poverty level, which is approximately $48,000 for the year that I'm talking for 2025, the year that I'm doing this presentation. This is annually adjusted. It shifts just a little bit each year. If you have children or a wife perhaps or a spouse in the home, then the amount will change slightly. And then also you must reside in the United States in order to qualify for these services. Now, $48,000, it's not a lot of money. And so individuals who are qualifying for Ryan White funded services, typically speaking, may be of a lower socioeconomic means. Reimbursement for the cost of health insurance is something that the Ryan White program typically will provide. This may be plans such as a Medicaid or publicly assisted plan, Medicaid, Medicare. There may be a community plan or perhaps even a health plan through the ACA. But that's really valuable because once somebody is diagnosed with HIV and they have health insurance on board, a lot of times these are individuals who have never had health insurance that they might use the ER for routine medical visits because they don't have access anywhere else. So by having health insurance, they can begin to treat other problems, other medical issues in their life, not just their HIV. So what is the basics of understanding our terminology? What is HIV? It simply means human immunodeficiency virus. Immunodeficiency means your immune system does not work as well as it should as it attempts to fight illness. The human toll of HIV, the cost of the disease just in terms of the toll of human suffering, is pretty tremendous. It's tremendous. Approximately 40 million people have died of age-related illness globally since the start of the epidemic. We generally think of that in the early 1980s. And today, nearly that same number are living with the illness today around the globe. 39 million people estimated to be living with HIV today. In the US, 1.2 million people are living with HIV. And generally speaking, we think of this as having started in the early 1980s, but there were cases of individuals dying due to age-related illness long before that time. Robert Rayford, a young individual in St. Louis, is considered to be the first documented death from age-related illness in the U.S. This occurred in 1969. So after confirmatory testing that was performed in 1987, and it's estimated that HIV has been around in human populations since the early 1900s. We really don't know where it first started, but somewhere in Central Africa is the theory. But we really don't know exactly how long it truly has been with us when it made the leap into humans. So currently, there is no cure for HIV. As of mid-2025, 7 individuals are recognized in the scientific literature as having achieved long-term remission or a cure from HIV. With 5 out of those 7 individuals having resided in Europe where they received treatment and care. So the individuals that have been found long-term remission from their HIV, typically this has been following a stem cell transplant for cancer treatment, often involving donors with a rare CCR5 gene mutation. So the picture on the right is of the Berlin patient in 2009. He was the first individual that was thought to have been cured of his HIV. He had leukemia and received a stem cell transplant, but he also had a natural genetic mutation, the CCR5 gene, that made him resistant to the HIV virus, and then he received a stem cell donation as well. He later died due to complications of leukemia. But from 2009 to 2025, we've only had 7 individuals globally that we know of that have achieved long-term remission or a cure from their HIV. The 7th one most recently did not have the gene mutation, which really is impactful because it gives us hope that treatment, new therapeutics, new treatments are coming down are going to be coming along, and someday we may in fact have a cure. But we don't have that yet. And I see in my social media feed all the time that, oh, we've got a cure, that there's new treatment. Well, yes and no. So why is HIV so difficult to cure? Well, first of all, we have to consider the latent reservoir. The HIV primarily sequesters in the lymphatic and GI systems. It's also found in the brain, the bone marrow, spleen, and especially the genital tracts. Early on, HIV remain in a dormant state within cells, making it impossible to eliminate with current medications. The term dormant is a little bit of a misnomer. It's the fact that HIV, it takes a while to build up in the body and then it takes a while before it then begins to make a dramatic impact on the immune system. HIV mutates incredibly fast. It introduces tiny mistakes or errors, in a sense, as it replicates. But this allows it to evade immune defenses and develop resistance to drugs. This is why it's really important, and we'll talk about this also, when an individual begins to take HIV treatment, it's really important that they continue to take that treatment perfectly and adhere to their regimen, because if that does not happen, then HIV can continue to mutate, and then it becomes resistant to drugs. And then that's really a difficult situation because it then leaves us with very few options in ways to treat the virus. HIV specifically targets and destroys CD4 or T cells that manage the immune system to response to pathogens. So your immune system is made up of a lot of parts. A CD4 or a T cell is one part of your immune system, and we're going to talk about that also. And HIV inserts itself directly into the human genetic material, which cannot be easily removed without harming healthy cells in the process. So it's a really tough virus in order to find a cure for because of these particular factors. So what are the HIV transmission factors and stereotypes that typically comes with the transmission of HIV? HIV is found in the blood, semen, rectal, and vaginal secretions of an HIV positive individual, and it can be spread in the following ways: having condomless sex, whether that's vaginal, anal, or oral, with someone who is living with HIV. This could be a male or a female. Sharing needles or injection equipment with an HIV positive person. Typically, this is found in intravenous drug use. Perinatal transmission through the process of birth and/or breast milk. This is somewhat of a rare occurrence. Typically, if an individual comes in for labor and delivery into the hospital, they will be tested for HIV. Special medications can be given to both mom and baby to help prevent the baby from acquiring the illness. Breastfeeding may present challenges. Talk to your doctor about what's appropriate there. Blood transfusion or organ donors from an HIV positive individual. So this is rare because blood and organ donations are routinely tested for HIV as well. Having an STI or overdosing can also leave you far more susceptible to contracting HIV if exposed. Once someone is HIV positive, no test can determine when it was acquired. And I've got to tell you, that is the question that I have heard over and over that everyone asks: who gave it to me? Where did I get this? There is no easy way to answer that. There is no test that I can give or that a medical provider can give to tell you exactly when and where you contracted HIV. Where I live in St. Louis, there are some disease investigators who specialize in doing this kind of work. And I got to tell you, they're highly trained and they do it really, really well, but it's not easy. It's really not easy. And if in fact somebody is in contact tracing, if during contact tracing, if someone is needs to be notified that someone else, one of their sexual partners, perhaps somewhere in their life, had tested positive for HIV and encourage them to get tested, they know how to have those conversations. That is not something that sometimes I hear clients who are living with HIV say, "Oh, I've got to go back and tell this person, this person, and this person." No, not necessarily. Talk to know your clients, know the options about what's available there to help then potentially alert parties that may not know that they've had an HIV exposure. Continuing on with stereotypes, you cannot get HIV through sharing cups, plates, utensils, toilets, or any other non-sexual physical contact. HIV is not transmitted through kissing, hugging, touching, sneezing, sweat, tears, urine, fecal matter, or insect bites. HIV can be transmitted through oral sex, though this is considered to be very rare. It's also rare to contract HIV through cunnilingus, fellatio, mouth to genitals, and/or analingus, mouth to anus, with an extremely low to negligible risk. Sometimes HIV is thought to be a personal failure or a punishment for sin. I've heard that more than once. HIV is not a gay or deviant disease. That's a stereotype that I run into that one all the time. People assume that HIV is restricted to the population of men who have sex with men, but that is not the case. HIV is not a death sentence, and I hear that one quite a bit as well. Women with HIV are not vectors of infection, meaning that during pregnancy or motherhood that they will transmit the virus to the infant. 1 in 7 individuals do not know that they are living with HIV, that they are positive for HIV. And this rate is even higher in some minority populations due to concordance factors. Black and Latino men who have sex with men and transgender individuals are more likely also to be living with HIV and not know it. Now, nearly 60% of all HIV acquisitions occur in cisgender females, many of whom are heterosexual. Sometimes cisgender heterosexual females really have a hard time understanding how they could be more at risk. But if you think about the structure of the vagina and the cervix, there's a large amount of mucosal area where the virus can then pass through, and then if it seroconverts, then the person is now living with HIV. But a lot of times there's no symptoms early on with an HIV acquisition. So individuals may be living with the illness, but they don't know that they are. So, and people don't always get tested. They don't always think to ask if they're being tested by their medical providers. So HIV testing after potential exposure, typically an HIV rapid test, this could be blood or saliva, looks for HIV antibodies and is generally accurate up to after 4 to 12 weeks since the potential exposure. Now, sometimes people will go, oh, the next day or maybe a week later to get tested. It takes a bit of time for the antibodies to build up so that the test can then be accurate. If you are, in fact, if you do test positive for HIV with a rapid test, your doctor will order what's called an HIV fourth generation test to screen for the HIV antigen, which is more accurate. This is considered the gold standard when it comes to HIV testing. But again, it takes a bit of time. So if you're potentially exposed to HIV, you should retest at 3 months and again at 6 months to ensure that one is indeed negative for HIV. HIV rapid tests are highly accurate with about 99% accuracy. However, false positive results do occasionally occur. It's estimated a rate of around 40 false positives per every 100,000. And then false negative tests are typically associated with testing too soon after a potential exposure. So let's just talk about the terminology and understand what are the CD4 and the viral load, because these are really important measures of overall physical health when it comes to individuals living with HIV. The CD4 count and viral load are two measures which are most commonly used to determine how HIV may be impacting the body and the immune system and how much HIV is actually in the body. So first of all, let's talk about CD4 or T cells. Your immune system is made up by a lot of parts, including white blood cells. One type of white blood cell is called a CD4 or a T cell, sometimes called a helper cell. The CD4 T cells, they recognize virus and bacteria and help the body fight infection. The number of CD4 T cells in a sample of your blood is an important indicator of how well your immune system is working. A healthy immune system has a CD4 range from about 800 to 1200 cells per microliter. Somebody with HIV will have a much reduced CD4 T cell range. So the lowest that I've ever worked with somebody that when they came into services had a T cell count of 7. And if you think 800 to 1200 is in a typical person, but when somebody has HIV, then the virus will attack the immune system, typically the CD4 T cells, and then as those numbers fall, then opportunistic infections can enter into the body. Someone with HIV has a greatly weakened immune system, and when you have an individual like the one I just mentioned who came into services with a T cell count of 7, that means they basically have no immune system, that even a common cold can be disastrous for them. And it's really, really important to understand things about how do you prevent them from getting ill and how do you help them to understand that there are options and treatments that can help them then rebuild the immune system. But it takes time. It always takes time. HIV does not kill people. Instead, it destroys the CD4 or T cells, which allows for opportunistic infections to occur. So let's leave CD4 T cell counts for just a moment and talk about understanding what is the viral load. The viral load is a direct measure of how much HIV is in your body at this moment. Most individuals who are newly diagnosed have a viral load of approximately 100,000 cells per microliter. The goal of HIV treatment is to suppress the virus with medication treatments so it can no longer hurt the individual and the immune system then will rebound and remain strong. So as we treat HIV, so that viral load of 100,000 roughly will begin to come down. And when the virus drops below 20, the person is considered to be undetectable. Now, what does that mean? When somebody is undetectable, that means their viral load has fallen to 20 or less. And typically speaking, this is the limit in our ability to accurately test. So that's why we say that when the viral load gets down to 20 or less, that's really the limit of our ability to test, and we call that undetectable. So two really important things happen when the person is undetectable. We also call this virally suppressed. the virus can no longer hurt the individual's immune system, and they live a long, healthy, normal lifespan. And secondly, the virus cannot be transmitted to someone else. We call this phenomenon U equals U, and this is a term that came from the CDC. But when somebody is undetectable, when that viral load is below 20, then they cannot transmit HIV through sex to somebody else. And that's really, really important that we understand that and help clients to understand the importance of being undetectable. But somebody only gets to be undetectable if they are truly compliant with their medication regimen. And sometimes it's hard to say how long. So depending on where somebody starts in their when they're first diagnosed with HIV, depending on what their viral load is, sometimes they may get down to undetectable within a month. Sometimes it may be 6 months. Everybody's different. It all depends where you're starting and how your body responds to treatment. But typically, in my experience, it doesn't take a long time to get down to undetectable once somebody is, because the medication options that we have today are really, really good. So what is AIDS? So only when the CD4 or T cells fall below 200, then the clinical syndrome of AIDS is diagnosed. What is AIDS? Acquired immune deficiency syndrome. This typically takes several years of living with HIV and not taking heart medication to develop AIDS. AIDS is a very specific clinical syndrome as defined by having one of these two conditions. One, your CD4 T cell count falls below 200, or you develop an AIDS-defining condition, also called an opportunistic infection. There are approximately 24 specific illnesses, which some are more common than others. And I'm going to give you a list here of the ones that I've seen most commonly. So we'll start with candidiasis or thrush of the esophagus. This can also be in the trachea or the lungs. Sometimes you'll hear individuals say, even water tastes spicy to me, and I don't understand why. Typically, that's because they will have thrush. This can be treated, takes a bit of time, but it can be effectively treated. Pneumocystis pneumonia, PCP, this is a bacterial infection. There are treatments for PCP, but as the immune system gets really, really low, this becomes more and more challenging to treat. And sometimes individuals, they'll have special medications, breathing treatments, maybe they'll be on oxygen. I've seen this kind of play out in different ways, but pneumocystis pneumonia can be a challenge. Tuberculosis also can be a challenge. This is a bacterial infection. We think of it as strictly in the lungs, but it also can go to the brain, kidney, or spine. Herpes simplex virus. Herpes is a fairly common illness. However, when your immune system gets really, really low, chronic ulcers that last greater than 1 month in duration, and these can be challenging to treat as well. Cytomegalovirus, Epstein-Barr virus, shingles, each of those can also appear when the immune system gets below 200. Invasive cancers such as cervical lymphoma and Kaposi sarcoma, sometimes called KS, these also can occur. I've seen lymphoma in a number of situations in clients, and it's really tough. Sometimes they don't come back from that. As far as the KS lesions, the photos on the right, these are photos that we typically. So the photos on the right, these are images that show the KS lesions. And in the past, this has kind of been what we pointed to as the hallmark of somebody who has AIDS. But in my experience, I have not seen this all that much. It's a fairly rare, in my experience, it's a fairly rare occurrence to see KS. But if you watch films and read books, sometimes that's kind of the hallmark sign that everybody was looking for to realize then that they had a serious issue, possibly with HIV. Cerebral toxoplasmosis or primary CNS lymphoma, non-Hodgkin's lymphoma. Toxoplasmosis is a very serious brain infection. The brain is not a forgiving organ, and when toxoplasmosis or other issues go to the brain, this may then be defined as age-related dementia, as DSM-5 talks about it. Also, HIV-associated neurocognitive disorder or HAND can also be diagnosed. Chronic wasting syndrome due to HIV. This is significant involuntary weight loss, typically 10% or more of an individual's weight. So let's talk about terminology and treatment. The first highly active antiretroviral therapy, or HAART medications, were introduced in 1996, changing the landscape of HIV treatment and care. Prior to that time, we had some therapeutics. AZT is the one that most people seem to know about. Really tough, a tough situation when using medications like that. Until we had HAART meds, HIV was really, really difficult to treat effectively, especially in the early years of the epidemic. Today, there are numerous medications that exist for the treatment of HIV. However, there is no cure. Biktarvy, this is the medication that I see most commonly in my practice, or that I hear clients talking to me about. Biktarvy is typically it's well tolerated. There's very few side effects normally with this particular medication. It's a single tablet regimen where you take one pill once a day, which is well tolerated by most individuals with few reported side effects. Sometimes individuals, if they have GI upset or other issues, they'll switch to Dovato, which is another highly effective medication. These medications, they're a single tablet regimen. In the past, people have had to take multiple pills multiple times per day in order to treat their HIV. Today, we have 3 medications in one tablet: bictegravir, emtricitabine, tenofovir. This is what's in Biktarvy. So the problem is this, and this is why the Ryan program is so critically important. The cost of Biktarvy for a 1-month prescription, $5,400 roughly. $5,400 roughly for the treatment of HIV. That's 1 month's worth of treatment, and the individual must be treated for the rest of their lives or until we have a cure. So you can imagine with programs like the Ryan White program that will help them to pay for the cost of these medications, because who could afford that? Treating HIV is incredibly expensive to the healthcare system. And so programs like the Ryan White program really does a tremendous service to those who are part of it, who can then get access medications so that they live a long, healthy, normal lifespan. Even with people who've come into services that I've seen who have good commercial health insurance, sometimes copays are even $600, $700, $800. I've seen that happen. And there are some copay assistance plans at some of the pharmaceutical manufacturers and other government programs, but those are not long-term options. So it's really, really important that we have programs like the Ryan White program to help pay for the cost of medication. Individuals living with HIV, they must adhere to a treatment regimen for the rest of their life or until we have a cure. This must be done perfectly. Perfect medication compliance, meaning someone goes then and they get their prescription of Biktarvy, they take it for a week or two, and then they go off for the weekend, then they forget to take it, and they come back, and maybe they forget a few and take it here and there. So the problem is, if that happens, the medication then the level of medication in the blood falls to a certain level, and then HIV recognizes that there's not enough medication to keep it suppressed, and then it will begin to replicate. And those replications then that allows then for tiny mutations to enter. And the problem with that is if the mutations continue to happen, then the medication simply stops being effective in order to treat the individual. They may have to leave then Biktarvy or some other medication in order then to find another medication that may not be as well tolerated or have other side effects. It's just a really difficult thing when people are not compliant with their medication treatment. But yeah, the drug therapy simply stop being efficacious, and we call that virologic failure. If they are consistent with their medication adherence, it improves quality of life, mental and physical health as well, with better symptom control, fewer hospitalizations, less stigma. HIV has a near always fatal disease progression if someone is either not compliant or refuses to take medication. We'll talk in just a bit about why somebody might refuse to take medication and how to work with that individual, perhaps in the counseling setting. So understanding HIV prevention, or PrEP, pre-exposure prophylaxis. How do we help individuals who are HIV negative remain HIV negative in their lives? So typically speaking, PrEP, this is recommended for a number of different populations. This is a medication taken to help people remain HIV negative, to prevent them from acquiring HIV. It's suitable for most people. And we have two tablet medications that are typically the go-to options. One is Truvada, introduced in 2012. The challenge with Truvada is that the form of tenofovir and Truvada, it has some kidney and bone density issues. So it's really important that if you're taking that medication, that you follow up consistently every 3 to 4 months with your medical provider to let them do kidney urine test and look at the creatinine levels. If the creatinine level creeps up, there are options then about how that is then addressed. Perhaps it's a switch to Descovy. Descovy's been around since 2019. It has fewer problems, but there's less data on that as well. So talk to your doctor and understand your options. If you are a woman or a transgender individual, then you've got to talk to your doctor as well, because they'll make decisions about which one is appropriate for you. PrEP is these tablets are around 96% effective in preventing HIV via sex. And less effective for IV drug use, but they are still offer they do still offer some benefit for preventing illness. The out-of-pocket cost for medications like Descovy is around $2,700 per month. The Rhinewight program will not pay for that. However, if you've got health insurance, that will cover it. There are some government programs that will help cover the cost of Truvada. The CDC estimates that only 36% of Americans for whom PrEP is recommended are actually taking the medication, which is even less in some Black and Hispanic populations. So there's a great need for PrEP, but people are not always getting on that, and they need to have conversations with their healthcare providers about who is it right for, and what are the options that a person might have. Recommended for high-risk populations. I'll talk about that in a second. We also have injectable medications. The two primary FDA-approved long-acting injectables that we have is Apretude, cabotegravir, and Cabenuva, which is cabotegravir and rilpivirine. These are gluteal injections administered by a healthcare provider every 1 to 2 months, depending on where you're at in the cycle, replacing daily pills. These are a highly effective treatment. The cost, though, for cabotegravir, if you're using that for PrEP, is around a little over $5,000 per month for the lifespan. Sometimes that will be every 2 months. Talk to your doctor. What I hear most people reflect about these medications is that it's a fairly robust amount of liquid that's going to be injected, and that sometimes there is pain or redness or in the injection site. Yeah. So we also have now, and I think this is going to be the future of HIV treatment, long-acting injectable medications. Lenacapavir is the only PrEP option that can deliver 6 months of sustained HIV prevention at a time. This is well studied in most patient populations, but the cost of this is around $14,000 every 6 months for the lifespan, or as long as you feel like you need to be on that particular medication. It can also be used for the treatment of HIV, though that's a little more complicated, not studied well in some populations. Talk to your doctor; they can help you understand the options if you're looking for a long-acting injectable medication. So who should be on PrEP? PrEP is for sexually active adults or adolescents who are HIV negative, including men, women, pregnant women, trans men and women, and non-binary individuals as well. Individuals of any sexual orientation is appropriate. It's not just for gay men. And you don't have to be quote unquote slutty in order to be on PrEP. Anyone who asks for it, even if there are no identified risk factors, after a sexual health assessment, it can be prescribed. PrEP is especially important if you're in a high-risk category. Well, what are the high-risk categories? For instance, if your sexual partner does not know their HIV status, if your sexual partner has a detectable viral load, then it's really important to be on PrEP. If your partner had an STI in the last 6 months, or if you had an STI in the last 6 months, then PrEP should be considered. And if you or your sexual partner has inconsistent condom use and doesn't know their HIV status, then that would put you in a high-risk category. So if you are at high risk, consider getting on PrEP, or at least talking to your healthcare provider about what the appropriate options might be for you. So what about event-driven HIV prevention? So we have PrEP 211. This is a new, this is somewhat new, specifically Truvada, not Descovy, for use on demand. It requires taking 2 pills, 2 to 24 hours before sexual intercourse, another pill 24 hours after the intercourse, and a final pill 48 hours after that. This is effective for anal sex, providing 94 to 98% efficacy protection for those with infrequent exposure. If sex occurs over several days, 1 pill should be taken daily, continuing for 48 hours after the final exposure. This is not recommended for women or transgender individuals on feminizing hormones or therapy, or those who have receptive vaginal sex, as the medication builds up more slowly in vaginal tissue. Understanding HIV post-exposure prevention. So we went from PrEP, now we're talking about PEP. So PrEP is to keep you from acquiring HIV. PEP is also to help you to keep you from acquiring HIV, but this is after a particular sexual contact. So it's once a day pill taken by most people who are HIV negative to prevent acquiring HIV after a potential exposure. You may have been exposed to HIV during sex. You may have shared needles or other injection equipment to inject drugs, or sexually assaulted, or may have been exposed to HIV at work, an occupational exposure like a needle stick. If you think you were recently exposed to HIV, talk to your healthcare provider or an emergency room doctor about PEP immediately. It consists of a 28-day course of antiretroviral medication, typically a combination of tenofovir and tricidabine and dolutegravir. Tivicay is the one that I hear most typically mentioned. Sometimes that might get paired with Truvada. PEP should be used only in emergency situations. This is not meant to be for regular use by people who may be exposed to HIV frequently. It must be initiated within 72 hours of exposure. So now we're going to shift to a topic of the sexually transmitted illnesses and post-exposure prevention in order to help prevent acquiring those illnesses. So to do this, we use a medication, doxycycline. It's an antibiotic, doxypep, as it's called, is the use of this doxycycline taken within 72 hours after condomless sex. This helps to reduce the risk of acquiring bacterial sexually transmitted illnesses, specifically syphilis, chlamydia, and to a lesser extent, gonorrhea. So just a word about syphilis. If you test positive once for syphilis, you will always test positive, but that doesn't mean you have an active case. It's really important that you tell your healthcare provider that you have tested positive for syphilis in the past. Syphilis can be treated, typically an injection of bicillin. It requires 3 injections spread out over the course of several weeks. It's really, really important that individuals take all 3 of the injections for the medication. But that's sometimes a problem because bicillin is really uncomfortable when injected. So most of the time I hear people talk about, well, they get treated for syphilis once, but then they don't want to go back and get the next 2 injections. But it's really, really important that that happens. Syphilis can be life-threatening if left untreated. Chlamydia also can cause significant problems for both men or women, but doxypep is fairly effective in stopping syphilis or chlamydia from developing. To a lesser extent, gonorrhea. Gonorrhea can also be treated, typically a shot of antibiotics, Brosiferin or something like that. But the challenge with gonorrhea is that it's becoming more and more resistant to antibiotics. So in St. Louis, there's a drug-resistant strain of gonorrhea that is going around that is sometimes very challenging to treat. Doxypep shows fairly good effectiveness, particularly for men who have sex with men and transgender women, from preventing illness from developing. What it does not prevent, this is not a protection against viral infections such as HIV, herpes, mpox, or even hepatitis. So we're going to shift gears now and talk about counseling competencies and how do you work with individuals when they come in for services. HIV is a near fatal disease progression if someone is either not compliant with their medication or refuses to take the medication. So you might wonder, why would somebody refuse to take medication for something that can really have a significant impact on their health? So religious organizations, people with certain religious beliefs like Christian Scientists, followers of Christ, Hebrew Nation, I worked with a number of individuals of the Hebrew Nation. They opt for instead of modern medicine in favor of faith healing as opposed to modern medicine. Amish or Mennonite clients may opt for herbal remedies instead of medication. Vegan, Hindu, Sikh, and Muslim individuals, they may reject the use of these medications because of the perceived use of animal technologies or testing. And sometimes people will not take medication because they have this kind of chronic suicide, this chronic nihilistic death ideation. I've worked with several people who have struggled with this, who say they want HIV to be their cause of death. And it's really unfortunate when if you see individuals who refuse to take medication, the disease progression will happen fairly slow at first, but then it will rapidly worsen the longer that they go without treating their HIV. It's a horrible way to die. It's really, really sad in those situations. So sometimes though, people, we as clinicians, we're asked to support people in their beliefs and making informed choices. And they have agency to simply say, I don't want to take the meds. How do we support them in that? Sometimes that's really, really tough, heavy lifting for us as clinicians, knowing how to support the client in a way that they can feel valued and respected. Sometimes cultural beliefs, we'll look at HIV as a soul condition or a spiritual issue like demonic possession or sin. I've certainly seen this more than a few times as well, and they feel like only deity can treat the illness. So we're going to shift gears now and look at counselor competencies and look at some ways of working with clients. What I'm presenting to you today, this is how I work with clients. This is by no means exhaustive list of ways to do that, but this is what I've found to be fairly helpful for me in my practice. So I always start with what's called the H5 model. This is an innovative model of culturally tailored health promotion principles for serving traumatized populations. I was introduced to this model when I took a course at Harvard Medical School. This is taught by Harvard Program for Refugee Trauma as well. This is the model they use when working with highly traumatized populations of refugees, typically overseas. But it was really remarkable when I went in and began to understand and look at this model and how it's being implemented overseas in other places. It became really apparent to me that it was quite applicable to the population of people that I was serving. So the H5 model revolves around five principles: the human rights, humiliation, healing and self-care, health promotion, and habitat. These five overlapping dimensions of care, they center on what's called the trauma story. Trauma stories are stories told by survivors of painful events to someone that they trust. And that's really, really important, the word trust right there, because sharing these stories serves a dual function, not only of healing a survivor as they process and understand their traumatic experiences and how it relates to their life in these five dimensions, but also of teaching and guiding the listener in the process of survival and healing. So the individual is considered to be the teacher, and then I, as the clinician, I am in the pupil role of learning from this individual. I've really found this to be quite helpful in helping to promote individuals and encourage individuals to be very candid and open and honest with me about what they've been through in their lives. And the five dimensions just kind of give a simple way to understand and silo certain pieces of information that helps to understand then the individual as a whole. Just a word about the H5 model also before I move on. This is a program that you can so this is a continuing education program that is taught by Harvard Medical School in concert with Harvard Program for Refugee Trauma. It's about a 2-week program, and they will teach you all about how to implement the H5 model. Also really important here, this is not just for clinicians. This can be for counselors, for coaches, for educators, really for anyone, nurses, social workers. So this is a model that helps you to understand and work with individuals, but you don't have to be a licensed clinician to know and implement some of the principles that are found here in this particular model. If you do the program through Harvard Medical School, they'll teach you all about how to implement this and why this is so important. This has been adopted by the World Health Organization, is routinely used when dealing with the mental health of individuals who have been through pretty horrible stuff sometimes. So while the threat of AIDS has been diminished by new treatments, HIV still remains an intractable foe. So how do we carry our knowledge and enthusiasm forward to serve clients in a ways that supports and validates them in their decisions and how they choose to treat their illness? I've listed 4 books here on this side that I found to be quite helpful. This first one, Stigma, Discrimination, and Living with HIV/AIDS. That's a really powerful book. A lot of good examples and on how to overcome stigma and shame, especially. This is the problem that I see over and over in the populations of individuals living with HIV, the stigma and the shame that comes with the diagnosis, and the real challenge of an individual then being able to share that diagnosis with somebody else, whether that's a sexual partner or somebody in their lives that they love and care about. It's really, really important that individuals be encouraged to share their diagnosis with a trusted individual, someone, even if it's only one person, that can be really impactful for their health engagement. So my approach, the first thing I do is always try to establish rapport and develop understanding. This is where the H5 model really is helpful for me. And there's some trauma-focused approaches that you can use the H5 model to help implement and advance forward. I consider myself to be somewhat of a Rogerian person-centered counselor. This is the approach that I typically will use. This helps then to keep the emphasis on the client and the client's ideas about how they can improve or change their lives as they process through pieces that are often trauma related. I also use a strengths-based narrative therapy approach, which is coupled with EMDR. So I'm an EMDR certified EMDR therapist as well, and I use EMDR quite a lot in my practice. When I talk about strengths-based narrative therapy, so as part of the history-taking phase of EMDR, I will often do a very comprehensive timeline analysis with the client. So we will write this together, and then once the timeline of events is established, and individuals can then talk about certain periods of their life that may have been really problematic or difficult for them to survive. And then we go back and look at what was it I was telling myself at each of these particular events in my life. So I am unlovable. I am flawed. I am worthless. I am somebody who can't ever get anything right. Whatever those messages, those I am messages are, those negative cognitions, when people begin to then go back into their life history and look at all the times that they were being told that they were less than, or that maybe they told themselves that they were less than, people get in touch with feelings they didn't even know they had. And I've seen this over and over and over again. And I've never had a client tell me that, doing this narrative therapy timeline preparation work was not valuable. Everybody seems to get something out of it. And like I say, they often will find feelings within themselves that they never even knew that they had. And there's always seems like there's a lot of grieving and grief process that has to happen as well. And the interesting thing about grieving that I've realized is grief begets more grief. So it's kind of like a cascading effect. Sometimes I say a waterfall effect, because they're grieving the loss of the childhood, the idealized childhood that they thought they once had. And now they have to deal with the fact that, maybe it wasn't what I thought it was. And that's a grieving process that they will go through. I use motivational interviewing techniques to promote healthy change and medication adherence. That can be really helpful as well. And of course, mindfulness-based approaches, cognitive therapy, mindfulness-based stress reduction. There's a really great program. It's an 8-week program taught by Brown University. Anybody can sign up for it. You don't have to be a clinician to do that. They'll teach you all about mindfulness-based stress reduction or mindfulness-based cognitive therapy, depending on which class you sign up for. Those are really, really good. It's very valuable learning, and it can be really impactful for your clients to be able to have some kind of mindfulness-based practices that help them to then regulate, which oftentimes that's the challenge for individuals. So in my practice, about 70% of the HIV positive individuals that I will see identify as LGBT. And I want to say this really, really forthrightly, that it's critical to be more than just merely gay friendly. It's about being informed, LGBT informed, gay and queer informed clinicians. And I really like the books by Joe Court, LGBT Clients in Therapy. I think it does a great job. The other one, The Joy of Gay Sex, has a fairly lengthy section on living with HIV as well. And I think that book is pretty helpful as well to understand some of the principles of how gay or queer relationships may look different than your heterocentric relationships. But research shows that lower rates of counselor self-efficacy and acceptance and multicultural competencies among clinicians treating HIV positive individuals. So always ask people when I talk to them about their beliefs around HIV, what are your biases? And it's not unusual to hear someone say, well, I don't have any. Well, yes, people have biases. They may not realize they have biases. I certainly had to, to address some of my own when I began this work. There's the sexual orientation counselor competency scale, which is a way of a counselor going through an assessment that helps you to look at and think about potential biases. There's also the Swedish HIV stigma scale. Even though it says Swedish, it's actually in English, and this is for use when the clinician and the client alike to help individuals understand where their biases might be against illness. This can be really revealing, especially for your work with clients, as you look at how to support them. Of course, remember, discrimination always feels worse than the disease itself. So try to address your biases as best as you can and be aware of the fact that they do exist. These helpful assessments, I'll try to provide these along with the slide deck, and perhaps you can find them to be useful as well. So when it comes to HIV, let's talk about talking, because words truly do matter in working with this population. Always strive to fight stigma. So how do we do that? So I suggest to people that refrain from saying that somebody is HIV infected. Instead, try saying somebody may be transmitting HIV to another party, or somebody has acquired HIV. And I never use the word dirty or clean to refer to someone's status. These are kind of negative, pejorative words that can really carry a lot of heavy kind of implications. The idea about being dirty, that's just certainly something that we need to strive to not say and fight the stigma that comes with that. So an HIV diagnosis is a person living with HIV, or perhaps they're a person living with AIDS. The term gay or queer can be quite pejorative to some, especially to some older generations. So I use sometimes the phrase same gender loving. So I know it's a mouthful, but sometimes that can be softer and an easier, gentler way to work with your clients if you not refer to them as gay, but rather same gender loving. Never use the term prostitute, hooker, or whore. Instead, try using terms like sex worker. They may be engaging in survival sex, or maybe they're a sex trafficked victim or a sex trafficked survivor. I've worked with individuals who have come out of having been sex trafficked, and that's some really emotional, heavy lifting. And a lot of times, these individuals, they just have horrible stories of trauma that they will share. How they became sex trafficked in the beginning, and then what happened to them during that process. Those are tough cases, and but just be prepared that may be the individuals who you're asked to work with, and implement the phrase out of control sexual behaviors as opposed to allowing instead of the client, rather than labeling themselves as a sex addict, sometimes as a porn addict. I always try to confront that and not use the word addict as much as possible. Going back to refraining from saying HIV infected, this photo on the right, this is, we can clearly see that there is an infection happening in this individual's foot. It's like a visible open sore that you can actually see and understand that this is the infection that's going on. With HIV, you don't see it. They don't look any different than anyone else. Now, they may have an age-defining condition at some point in their life, but strive to fight stigma by not saying that somebody is infected, especially when it comes to HIV. Sometimes I will use the word sexually transmitted infections. I prefer sexually transmitted illness, but use your own judgment on whether you think that word is appropriate. Typically with illnesses like syphilis, gonorrhea, you typically can see the visible result of infection, but not with HIV. It's quite different in that regard. So the unique nature of HIV positive clients, I want to tell you that if there's one thing that I've realized is that when somebody is given an HIV diagnosis, how you tell them and how you support them immediately after they've been told has a whole lot to do with how they will cope with their diagnosis. And I've listed for you here 5 different examples of ways that I've seen people cope, or at least attempt to cope with their HIV diagnosis. First of all, denial coping. This really is the embodiment of hopelessness, and it leads to a much faster disease progression. People who just deny the fact that they even have an illness that needs to be treated. Denial, it can be really, really difficult to overcome, to help support clients in a way that honors their autonomy to make decisions for themselves, but while also encouraging them to think about their sexual partners or the people in their life that they love, how their denial is going to impact their denial will impact them in their relationship to others. Passive coping, this is illness avoidance, disengagement, resigned acceptance, realizing and acknowledging they have an illness, but just don't really seem to want to do much about it. Just this passive coping can also be challenging to work with when we try to support clients. Confrontational coping, this is where an individual is characterized by anger, often taken out on others. So I have worked with individuals who are really, really angry about the fact that they are now positive. Maybe they feel like they were exposed to HIV because of a sexual partner that did not tell them of their illness. And sometimes they will want to take that out on other people by spreading HIV to as many people as they can because they're angry about the situation. I've seen that more than a few times, and that can be challenging to work with as well. But then there's active or adaptive coping, and these people, they have clinically better outcomes. These are people that acknowledge the illness and are committed to treating the illness, and so that they can live a long, healthy, normal lifespan. Sometimes suicide attempts may be a way of provoking a coping response. And I know that sounds paradoxical, but this may lead to a shift in the psychological distress tolerance while seeking a new commitment to life. So if they attempt suicide, they're not successful. Sometimes they have found their bottom, so to speak, and then they can build upon that and then go out and become advocates for other people to get tested and to treat their HIV. I feel like the greatest client need is acceptance of their chronic health condition, which, as we've talked about, demands medication adherence for the rest of their life. This is heavy emotional lifting, and it is rarely easy, I have found, with anyone to accept the fact that they have a condition that must be treated for the rest of their life, if that is what they choose to do. But just be prepared that that can be really heavy lifting as a clinician to help encourage and support people as we encourage them to treat their illness. Most often, these are individuals who I work with that have never had a chronic condition before, requiring routine medical follow-up and treatment adherence. So that can be hard for somebody to accept as well. Modern medical advances means far fewer people die due to age-related causes, but it really is important when you go into this work to realize that sometimes your clients will die. It's rare today, but it does happen. And it's really critical to go in with eyes open to that possibility and be okay with working with individuals, knowing that some of them, they may not survive the illness. So for the HIV positive clients, finding the courage to share their diagnosis with another person is the single most critical step for their long-term health and wellness. I can't tell you over and over again, I have seen this play out for individuals who choose not to share their diagnosis with anyone, and there's lots of reasons why somebody may not want to do that. But these people, they don't do as well in treatment typically. They're not as adherent, it seems like. I've just seen the psychological impact of individuals who hide with their diagnosis from themselves as well as from others. And that acceptance, that's really some heavy lifting also for us as clinicians to be able to support clients in a way that where they have the autonomy to not share that diagnosis, but at the same time encouraging them to do so. There's a balancing act there that has to happen. You got to know your client really well in order to know how to do that, to do that heavy work. So there's a great need to overcome stigma and shame as well. HIV is typically thought to be a gay disease or based on some moral failing. I can't tell you how often I have had to confront those ideas, especially the idea of it being a gay disease. Your heterocentric clients often struggle to process that particular stigma, thinking that how did I become HIV positive if I'm not a man having sex with men, if I'm not gay or active in the queer community. I've worked with a lot of heteronormative, heterosexual, cisgender women who really struggle with that stigma as well. Some people actively seek out ways to either transmit HIV or acquire the illness. Um, this may be based on a number of psychological factors, a sense of belonging. I've worked with individuals in the past who have allowed themselves to become HIV positive in order to be considered part of now this is the word that I've heard clients use, part of the club, and that they because in the past, when especially in the 80s and the 90s, individuals who had HIV, they were kind of a pariah, or so they described themselves as having been, and they couldn't find individuals unless somebody else was also living with HIV in order to, to have consistent romantic relationship or partnerships. I've worked with individuals who have allowed themselves to become HIV positive in order to be with an individual. Remember, this is a in a those decisions may have happened at a time before that we were even around or had much awareness of what was going on. That's not the most unusual thing to hear. I know that may sound like really paradoxical as well, why somebody would allow themselves to become HIV positive, but sometimes that does happen, and you'll hear those stories. And sometimes individuals will have a victim mentality, and sometimes individuals want to be living with HIV in order to have the secondary benefits that come from programs like the Ryan White program. Um, yeah. So and always remember that a feeling of discrimination is often it's worse than the disease itself. So men are more likely to report their diagnosis as having been traumatic when they received it than women. I don't quite understand that one, but that's something that the research has borne out in a number of different studies. Concerns with sexual health and wellness, it seems to be a universal misperception when people are newly diagnosed with HIV. It's really common to hear somebody say, I will never have sex again. Like, my God, my life is over. I'm going to die. I will never have sex again, or I never can be pregnant again. Both of those statements are untrue. Don't be afraid to discuss your client's sexual health and wellness, and maybe that doesn't need to be stated to the individuals who are viewing this material, because we spend a lot of time talking to our clients about sexual health and wellness. But I guarantee you, they are thinking about it. So if we apply the implicit model, give permission to share to your clients, encourage them to share what they want to share or what they do not want to share. But the implicit model suggests to us that this is a way of working and understanding how we frame the discussions with our clients and the way that we think about autonomy and their ability and willingness to share can certainly be can be valuable. So some of the suggested language that I have found it helpful whenever I'm encouraging people to share something about their sexual health and wellness. So I will always ask, if you are comfortable, can we talk about your sexual experiences and health? So I always frame it in the form of a question and give them the autonomy to say either yes or no. Or I'd say, I'd like to ask a few questions about your sexual health and relationships. Is that okay? Uh, if discussing your experiences related to sex brings up difficult memories, we'll pause, we'll do grounding, and we're going to keep you safe. Does that sound okay? So those are just some of the language that you'll find your own language to use, but I always phrase this in a way that allows the client to either say yes or no, that they are willing to talk about any particular topic. So be aware of the potential for countertransference, especially as you work with individuals who we may have biases about. So we may assume the responsibility of disclosing a person's HIV status, that it to an unknowing sexual partner rests solely on the HIV positive individual. Yes, true in some ways. However, what is the responsibility of the sexual partner's responsibility in either asking or using safer sex practices? What if we assume everyone is positive? So there's two ways to look at that. What is the relationship between the individual and the person that they want to be sexual with? each of those individuals has a responsibility. And how do we balance that in a way that we help support clients? We may countertransfer our own personal moral or religious beliefs onto the client regarding this really, really important topic. I typically will take a sexual health history from individuals. We'll talk about the number of roughly their estimate of the number of sexual partners. So we may feel that 50 recent sexual partners in the last, let's say, 3 months is out of control. But however, the real central question there is, what does the client believe about that? Is 50 partners out of control for them? Maybe that's not at all. But it's easy for us to impart our own bias and beliefs onto individuals and thinking, oh, that's out of control, that's too much. But what does the client believe? And always reinforce the principles of sexual health for the client and the clinician alike. And if clients do not trust the system of care, they will not engage with it. So expect to have to earn your client's trust, and that takes time. It always takes time. Sometimes conspiracy beliefs may be part of the HIV diagnostic picture. And I cannot tell you how many times I've confronted these beliefs, such as the government is simply trying to eliminate either poor people, Black people, and gay people, and that they believe that HIV and AIDS is the government's way of addressing that and trying to kill people off. That can be really tough. And if you're going to have success in addressing those beliefs, those false beliefs, you got to earn the client's trust in order to be able to go there. So the typical client that I will see is between the ages of 13 to 45. Yes, that means adolescent youth. Typically, I don't work long term with anyone who is younger than the age of 20. There's some special therapists in St. Louis who deal with the youth population. They do a fantastic, fabulous job. But yes, if you're an individual who does work with adolescent population, then somebody as young as 13 may in fact come into services and that you might be able to help. About 60% of the individuals that I see also tend to be Black men who have sex with men and or transgender women, especially trans women of color. This has everything to do with the concordance factors and why the Black and Hispanic and transgender populations are disproportionately impacted by HIV. People engaging in survival sex is not uncommon, and disclosure of diagnosis is really challenging for these individuals. And this has a lot to do with the HIV criminalization laws. So if I'm living with HIV and I know I'm living with HIV and I have sex with somebody and I do not warn them that I am positive for HIV, that can be considered a felony in 32 different states. 32 states still have criminalization laws. And the problem with these laws is they were established typically in the 80s and 90s when we didn't have a lot of information. There was a lot of fear around HIV. And the idea was that it was going to keep the population safe from individuals who might transmit the illness to another party. Well, the problem is if you don't know you're living with HIV, then you can't be prosecuted. But the problem with that is that people don't want to get tested. So that's the challenge with the criminalization laws. Some states have eliminated those. In Missouri, they recently changed this. Somewhat. It's still but they still do have criminalization laws. But at least some of these laws have been updated to reflect what we know today versus the fear that we had in the 80s and 90s. It's really sobering, I think, that multiple studies that have looked at the issue of HIV and found that significant episodes of trauma across the lifespan, it's nearly universal in the HIV positive population. I see it all the time in my population of people that I work with. There was a really great study, the CHASE study. This is coping with HIV/AIDS in the Southeast. This was the work of Catherine Wetton and her team from Duke University, looking at the health outcomes of individuals in the Deep South. In the U.S. Deep South, this is where the epicenter of the HIV epidemic is in America today. And in the Chase study documented that these individuals, nearly all the participants, as having experienced a combination of either rape or sexual abuse as a child, physical abuse, neglect, family violence, and early loss due to the death of a parent or caregiver. Something else that really interesting that came out of the Chase study, they found a large cohort of individuals who had been in the foster care system. Now, this supports what I see as well, because it is really remarkable that I would estimate about 20% of the clients I'm seeing have had some interaction with the foster care system as a youth. So the general population in the US is about less than 2% of individuals have had any interaction with the foster care system. However, I would estimate 20% of the people I'm seeing have been somehow involved in the foster care system. There was virtually no research on this, and it really is an interesting question. And this may be something that you will see in your client population as well. Just realize that if somebody has been in the foster care system, their attachment style may be altered as a result of that placement. It's not every case, but people who have anxious attachment styles or avoidant attachment styles, it has everything to do with how they're going to engage with you in the clinical setting. So understanding that their background is really, really important, especially if they've been in the foster care system for those reasons that I mentioned. The most common mental health conditions that are comorbid to an HIV diagnosis: depression, anxiety, sometimes out of control sexual behaviors, and especially complex trauma. Those conditions are all complicated if there is, in fact, also the comorbid diagnosis, such as bipolar disorder and schizophrenia. This is especially problematic in your unhoused populations, especially schizophrenia. And this is where long-acting injectables are really important, because if somebody is unhoused and they have no permanent residence where they can keep their medication safe, they can be consistent about taking the daily pills. So this is where long-acting injectables may be a good option to help individuals to treat their HIV if they do not have some of the most basic of housing and food and just the things they need for daily survival in life. So when I'm working with an HIV positive client, I always assess for the substance use. So HIV and chemsex, this is a really interesting syndemic. So polysubstance use for sexual enhancement is sometimes a factor. The most common substances that I hear about are those that enhance sexual pleasure. This is methamphetamine. Meth can be injected, smoked, snorted, or what I hear people talking to me about is the booty bump method. And the booty bump is so when an individual smokes or injects meth in will be excreted as meth out. So they'll excrete methamphetamine through the skin or through urine. So the body does not break down the components of methamphetamine. So meth in is equals to meth out. So individuals in the booty bump method, they may urinate into the rectum of another individual in order to pass methamphetamine from one person to the next. So the problem with that is overamping, meaning we don't know how much meth we're getting or taking into our body if we're getting this from somebody else. Meth remains in the body for 8 to 12 hours. So this can build up over a course of time, leading to severe health problems, especially cardiac issues due to overamping. So MDMA, Molly, or ecstasy, I hear people talk about using that. GHB, this has a sedative effect, and it also has an analgesic effect, meaning along with poppers. So if somebody is engaged in anal sex, they may be damaging themselves, harming themselves, but not realize that they are doing so. Physically harming themselves, but they may not realize that they are doing so due to the sedative effects, either GHB and the relax and poppers, which are an inhalant use to relax the anus muscles, which is risky also for hypotension when used with PDE5 inhibitors like Cialis and Viagra. Ketamine, Special K, produces euphoria, but erection problems are typically associated with ketamine use. So the two books on the side, Lust, Men, and Meth, this is the work of David Fawcett. I really like these books, and the one on top is a study guide or a workbook for your client that they can use or that you can use to help guide the conversation and questions to support the client. Sometimes people will want to stop their methamphetamine use, but a lot of times what I hear is I use a harm reduction approach. So if I can convince them to maybe cut back on their methamphetamine use, then that's where we'll talk about and work with the client. It doesn't always mean stopping meth use. This other image that I've got here, this cell phone looking image with the MTV astronaut. So sometimes you will see this image. I see it sometimes on Grindr or Scruff, sometimes on Sniffies. So what this is advertising is typically a sex party. It's advertising an event where individuals can get together. Typically, that I see men who have sex with men, and what MTV stands for is meth, Truvada, and Viagra. So people that go to what is called MTV parties, that's what they're talking about. And this is sometimes the imagery you'll see online that advertises if you're interested to reach out to this individual, and maybe they'll set you up with wherever the party is happening. But they're providing meth, Truvada, and Viagra. So just a word of caution about people who engage in chemsex. About I about 90% of those individuals, if they're so meth can be smoked, snorted, or injected. So if people want to inject, usually it's a crystal. They'll put it into a syringe. They'll put some tap water in, shake it up, it dissolves, and then they inject. So if people are sharing needles, about 90% of those individuals will also have hepatitis C, which is the leading cause of liver cancer and liver failure in the US. Hepatitis C can be treated successfully. It's a long treatment, it's an expensive treatment, but it may not be appropriate for some active IV drug users. Talk to your doctor about whether or not this is appropriate for you. In the past, hepatitis C treatment was only effective for once in a person's lifespan. I don't understand the science exactly why that was the case, but I think I see advertised online some medications that suggest that this can be also used today more than just once. But talk to your doctor, understand the options there. And anytime that I'm working with somebody who has a history of chemsex or substance abuse, I'm sorry, substance use, not abuse, but substance use, I use the 5 A's method for addressing substance use. First of all, screen for substance use, how much. If you ask your client, how much methamphetamine are you using? You'll never get a straight answer. At least I never get a straight answer. But if I ask them, how much are you spending per week on your meth habit? Or how much are you spending per day or per month on your methamphetamine habit? That gives you a lot better picture as to how much that somebody is actually using. Advise, encourage them to stop or reduce their use. Assess the client's willingness to stop. Motivational interviewing techniques can be helpful here. Assist the client in testing routinely for STIs. And then finally, arrange. Make a plan with the client to revisit the topic again. Always ask for permission to come back to the topic, but try to arrange a time when the two of you can, or however many clients you're working with in a setting. This is appropriate also for group settings. Arrange to make a plan to come back and revisit the topic again. So the challenge with chemsex, sober sex for clients who have previously engaged in chemsex can be very difficult to navigate. Having sex after consistent use of substances like methamphetamine to enhance sexual pleasure, it can be a real letdown when you're trying to have sex without the methamphetamine. So have an open dialogue with clients about the stressors of sober sex and temper their expectations for sex in the early recovery period. They may find that sex just isn't pleasurable anymore. It can take up to a year for the body to fully recover after methamphetamine use. Connecting clients with group support regarding sexuality and health can be an important resource. So I think about groups such as the ones that Michael Vigorito runs for individuals with out of control sexual behaviors, where substance use is also, it sounds like, part of the work that he uses. So I use his book in order to kind of help inform me about, if I'm working with groups, about how to do that. And I always encourage clients to re-explore sexuality in creative new ways. Now, this aims to reduce the risk of recurrent methamphetamine use. And sometimes you've got to get creative to help clients understand that they can, in fact, have sex without the substances. But sometimes that's really heavy lifting as well. I use a harm reduction approach, consider the client's goals regarding reduced or safer participation. So I'm nearly wrapping up here with today's talk. So I want to talk about counselor competencies because this really is important when we talk about the code of ethics and the critical factors in decision making, especially if we're considering disclosing a client's HIV status to a third party. Now, most of the professional counselor and ethical codes and laws allow for breaching confidentiality when needed to prevent serious, foreseeable, and imminent harm to the client or a third party, others. So the potential transmission of a life-threatening illness can meet the threshold of disclosing somebody's private information to a third party, depending on a couple of specifics. There has to be a level of risk, there has to be foreseeability of harm, imminence of harm, and does a position of powerlessness exist in the third party? The ACA Code of Ethics, the Social Work Code of Ethics, and the APA Code of Ethics, each of those codes do allow for an individual to perhaps breach confidentiality in certain situations. But I'm going to tell you, this is really, really challenging work, and you can't just go out and just tell everybody's stuff to someone else. Yeah, sometimes I'll provide case consultation to other clinicians who are struggling with should they disclose the life-threatening illness to a third party. I always recommend this book, Ethics in HIV-Related Psychotherapy. This is published by the American Psychological Association. You can find it on their website, or I think it's on Amazon as well. I like this book because it gives you a lot of different case studies that can help you to understand maybe some of the ethical requirements a little bit better. But the problem with this book is it was published in 2003 and has never been updated. And a lot of things have changed since 2003 when this book came out. So if you're going to think that you need to make a disclosure about somebody's HIV status to an identifiable third party, just document, and seek consultation, whether that's from another a clinician or a lawyer, or always seek consultation and document your rationale for whatever decision you make on that. Because it's really easy to feel trapped and not knowing what to do. Because public health statutes may also require reporting or partner notification for certain illnesses. Always follow the applicable code of ethics, state law, and agency policies. At one time, I worked in a different state, and I was not allowed to put HIV into somebody's clinical notes. I was instead required to say that they had a blood-borne illness or a blood-borne disease, but I could not say HIV. So know your state's laws about disclosure as well. And when disclosure is justified, limit it to the minimum necessary information and always obtain consent if possible from the client and have their buy-in. Because if you disclose their HIV status to another third party, feeling like you did the right thing, it will erode trust. It has the potential to erode trust and dissolve their willingness to trust you or to come back for services. And it can have a really negative impact on how they engage with services with somebody else in the future as well, if they can't trust that their information is going to remain private. Counselors must also adhere to the relevant state laws, and 32 states still have harsh HIV criminalization laws. So you may be opening them up to criminalization, criminal prosecution, if you in fact do make disclosure. Like I say, this is really heavy stuff, and you've got to seek adequate support and consultation before you make any type of disclosure. So set and setting is really important when doing this work. When I say that, I'm thinking about the mindset of myself as well as the client when they come into my space. This is a picture of my office and the way that I have it set up, and I'm sharing this to make a couple of points. First of all, warm, neutral earth tones is my approach in order to help them to feel soothed and calm in the setting. I also use a dual couch setup, and there's about 4 feet between the two couches. So I've never had a time when I've, bumped the feet of somebody else. But I like the fact that there's no chair of power, that it's a fairly egalitarian setup where individuals can sit on the couch. Typically, I sit on the left, client sits on the right. And I want the client sitting on the right because of the bookcase that I have here as well. Now, when I put that in, I wasn't sure if that was going to be helpful to clients because I was afraid it would be too distracting. But what I have done though, and this is the reason why I'm showing you this picture. So if you have a bookcase, for instance, in your office, the type of books you put on that bookcase can really inspire people to have certain dialogues and have questions that they might ask based on what they see on your bookshelf. So on my bookshelf, almost all of my books are related to sex therapy, sex counseling, having a better sex life, tantric sex. Uh, it's really interesting because clients will look at books on my shelf and sometimes we'll stand there together and look at books together and I'll make recommendations on things they can read and try and or I'll get up in the session and it's like, oh, look, I've got a book right here that maybe will be helpful for you. That's partly why I do it. And when I go back to the implicit model and permission to share, so when clients see that I've got a 3 volume set on tantric sex for lovers, that particular book, for whatever reason, seems to open up a dialogue with people about their sexual health, but it's signaling to the client that the topic of sex is okay to talk about. And when you're dealing with people living with HIV, I guarantee you, sex is on their minds in the sense of how do I have sex again and feel safe and not feel like I'm going to put somebody else in jeopardy by transmitting an illness. It just opens the door for conversation in new and unique ways. The last thing I'll mention about my office, so there's an image on the wall of an individual. It's kind of a mysterious image that I really, really love. But sometimes to get clients talking, I will ask them to look at the image and maybe just tell me a story. What do you see? What do you think's going on? What do you think's happening in this image? How do you feel when you look at this face? Watching how people interact with the faces of others can be really, really interesting because there's always a lot of projection in that, and understanding maybe how they see themselves can come out in the way that they describe how they see others. So this is my office. It works really great for me, and I'm really thrilled the way it turned out. But if you have books on your bookshelf or other things in your office to signal to clients that it's okay to talk about sex, that's pretty cool, actually, is what I've experienced. So I'm going to leave you with just a few other recommendations as far as books. This first one, The First Year of HIV, you can find this on Amazon. When I worked in infectious disease clinical settings, the drug reps would give me these books, and I would give them to my clients pretty much all the time. And but you can find this book on Amazon. I forget what the publication date was, but it's at least 10 years old, I suspect. Um, while some things have changed, a lot of things have not. Anyway, it's a pretty good book. The other one on the right. So if you do not read any other book about HIV, I'm going to encourage you to read this. This is the book that I really recommend to anyone, any clinician trying to understand the intricacies and involvement of working with HIV and client populations. This is the book that Catherine Wetton and Brian Pence published after the Chase study. I mentioned that just a minute ago. This is case studies that they found of the individuals they were working with in that study. And it is absolutely heartrending to read these accounts. But as one individual in this book described their life, they described HIV as simply being the cherry on top of an already bad life. And if you read this book, the human cost of HIV, you cannot ignore that fact as you read these accounts of as told in this book. So Gilead, I know it's a pharmaceutical company. They are very they have a robust number of HIV related medications. They did a series of documentaries documenting HIV in the American South. This is really, really good material. I got to tell you, watching these videos, each one is about 20 minutes long. I think there's 6 or 7 videos. Sometimes I will watch these in session with clients, and then we'll talk about what they saw. But people can see community in these imagery, and the imagery is promoted in Blind Angels. That's the name of the series. Each one is a little bit different, but it really does open a opportunity for a dialogue about how they see themselves as well as how they see and relate to the individuals in the video. These are stories that are told of resiliency, of overcoming harsh stigma, harsh shame, overcoming the negative feelings of being diagnosed with HIV. I highly, highly recommend this series. I wish I could show them here, but I've got the web address there. You can go to it and check that out and see if that's valuable to you or maybe the clients that you're working with. Really, really good series. It's called Blind Angels. If you want to watch a show, here are a couple of recommendations. It's a Sin. This is on HBO. This is about five queer youth living in London during the height of the AIDS epidemic in the early 80s and 90s. And it follows their story. It's really, really good. It's an enjoyable show to watch, though it's be prepared for maybe for a cry as well, because there's some sad parts to it as well. But also The Normal Heart. This is the movie that was made based on the play by Larry Kramer. And The Normal Heart, it really is a dramatic story about living and loving and dying and surviving in the height of the AIDS crisis in America. And it's a powerful play. It's a powerful movie. Check that out. It's on HBO as well. Holding the Man. This one is on Netflix, and it's set in the 1980s as well. And then also Dallas Buyers Club. Jared Leto and Matthew McConaughey won an Oscar for his performance in this particular show. It really is dramatic. It's very heart touching as well. What it's like, what it was like during that time to be diagnosed with HIV as well as AIDS and given only a short time to live. But it's a survival story, and it really is valuable in informing maybe how you think about HIV today, and the really tremendous heavy lifting that people will go through in order just to survive and have a life of their own. And that's at the end of the day, that's what everybody wants, is just to have a life of their own, that they can live their life on their terms. And so the final thing I'll leave with you is AIDS stays forever if we only think of it on World AIDS Day, which is December 1st. Get tested, know your status. If I can encourage you to do any one thing, it's that. Get tested, know your status, encourage your clients to know their status. And remember, 1 in 7 do not know they're living with HIV. So know your status. I can't stress that enough. And that's it. Okay, I know that was a lot of material. I hopefully you found it helpful or beneficial in some way that can inform your practice. I promised you a story, and I'm going to take a quick pause, and then I'll come back and share just a brief bit of information about how I got involved in this work and why it is so impactful for me today, and why I hope it will be impactful, maybe to inspire you to become involved in this work as well. I remember the following words as they were delivered from a podium of certainty when someone said, "We feel this play is designed to draw sympathy to the so-called plight of the homosexual. There is a necessity that theatrical productions put on by this college be those of decency and represent Christian morals. And make no mistake, we are totally intolerable of the lifestyle and of the homosexual act of sodomy. You cannot teach this sort of filth and answer to no one. Homosexuality is not normal, and the battle for morality in Springfield, Missouri is simply too important to stay silent and let the normal heart go on." A play written by a radical and militant homosexual, Larry Kramer, that only promulgates the sickness of the homosexual lifestyle and does little to address the issue of AIDS. These are the words of Jean Dixon, a conservative state legislator from Springfield, Missouri, who formed the activist group Citizens Demanding Standards in 1989. She did this to oppose a production of the autobiographical play by Larry Kramer, The Normal Heart. The play was to be put on by Southwest Missouri State University, now known as Missouri State. And as many of you know, The Normal Heart is a dramatic story about living and loving, surviving, and yes, even dying at the height of the AIDS crisis in America. And this was my first true introduction to the issue of HIV and the plight of those living with AIDS. In 1989, when the controversy first erupted, I was a young 19-year-old, deeply closeted gay college sophomore on the campus of SMS. I cannot overemphasize to you the degree of conflict that came out of this, the outpouring of bigotry wrapped in the guise of prayer for the fact the university could just dare to whisper about, let alone talk openly about what was thought to be a gay disease like AIDS. And it had not been that many years earlier when AIDS had been known as GRID, gay-related immune deficiency. And while I don't know who coined the phrase GRID, I can assure you that living in Springfield, Missouri in the 1980s, a community with over 300 different fundamentalist and evangelical religious organizations, it did a great disservice by stereotyping in people's minds that only those who were gay could acquire this disease. And yes, it was terrifying. There was no cure. There was no long-term treatment options for this disease. If you had AIDS, you died. And it was really just that simple. But then an interesting thing began to happen. On campus, I began seeing individuals wearing red hearts cut from bolts of felt cloth, pinned to the lapels of both faculty and students alike. And while I wasn't entirely sure what those red hearts symbolized, until my psychology professor walked into a lecture hall one October morning with a red heart pinned to her chest, and the reaction from some students was nearly immediate. She received taunts and jeers, being heckled by those in the room for the fact that she could be a lover of those people. Those people. And I won't repeat the slur they used, but it hurt, and I never forgot it. But she didn't flinch. And when she began to speak, she simply stated to the students, there is nothing more immoral than allowing people to die of ignorance. And I want you to live, and I will not passively watch far too many of you continue to die. I was touched deeply by her compassion, her humanity, and she was speaking directly to me. That night, I went home and cut out a red heart to pin to my own lapel. And come hell or high water, I was going to show that I too wanted those around me, students, friends, lovers alike, to not die either. The red heart you see that I'm wearing today is the very same red heart I wore in the fall of 1989 at the height of the controversy. But wearing that red heart, it was not so simple for me. You see, in 1989, I was laser focused on becoming a military officer and being commissioned in the United States Army. Because of my involvement in the ROTC program, I would often wear my battle dress camouflage uniform on campus. Within days after I began pinning that red heart to my chest on the uniform, an act less of rebellion than of pleading, I was called on the carpet by Cadet Command, and I was told that if I continued to wear the heart on my uniform, I would be summarily ejected from the military ranks, and my ROTC scholarship that paid for my education would be quickly stripped away. They were saying, wear that heart and be unfit for service. But I protested, telling them that I wasn't gay, being completely untrue to myself. But no matter, they said, in those days you could not be gay and serve. And by you wearing that red heart, it simply says you support those who are gay, and we don't need that kind of person wearing the uniform. From that hour forward, my red heart was pinned to the inside of my uniform, unbeknownst to military commanders. The camouflage being a kind of metaphor for my own existence, where the fabric could not be seen and the truth could not be punished. But I thought to myself, what that red fabric symbolizes to me is now simply a little closer to my heart than it had been before. Why do I serve today working with the newly diagnosed HIV positive individuals? It's simple. I was mad as hell, and when I experienced hate, then the adversity became personal to me, and out of my anger, I was able to make meaning of those early experiences in my life. And out of that meaning, I was able to forge an identity as a now openly gay man and an activist for HIV education, prevention, and treatment, who never forgot the controversy nearly 40 years earlier, and a college professor who did not want me to die, unlike far too many others in my life with this disease. The activist Harvey Milk was once asked by a younger gay man what he could do to help the movement. Harvey Milk said simply, go out and tell someone else, because there's always somebody, like Gene Dixon, who wants to confiscate our humanity. Yet I believe there are always the stories of the lived experiences by others which restores that humanity. And I believe if we live out loud, we can trounce the hatred and expand everyone's lives. I want to leave you with two postscripts to the story. First, the Taylor Health Center, the student medical clinic on the SMS campus, well, they completed more HIV tests and handed out more literature in 1 week following the 5 sold-out productions of the normal heart than they had done in the previous 5 years combined. And second, Jean Dixon, the founder of Citizens Demanding Standards, whose bigotry railed against the normal heart being produced, well, she was challenged in her party's primary and was summarily defeated less than 9 months after the normal heart controversy first began. She was defeated not because anger beat anger, but because truth and humanity were louder than anyone could silence. I encourage each of you today engaging in the fight against HIV, find a way to make meaning and create identity. Make meaning, create identity, and then invite the world to share in your passion. Thank you.